we have with us Dr. Alberto Zambon, and yes, he's the professor of medicine, University of Padova, Italy, and he's assistant professor of medicine division of endocrinology and nutrition in University of Washington, USA. So welcome, doctor, and thank you, Dr. Carlos, again.
Yeah. Thank you. Thank
and,
you, Carlos.
The ground is yours. Yeah.
Thank you very much.
Thank you so much.
Let me share the screen. Can you confirm that you can see the screen?
Yes, but you can make it full screen.
Yeah, I will. Okay, that's it.
Yeah,
dear colleagues, good afternoon. It's really a pleasure actually to share with you the next 30-40 minutes. Changing subject this time, we're gonna basically focus on lipids and cardiovascular disease prevention. And again, my only regret is not being there in person, but I'm sure there will be other opportunities actually to meet you in person. The topic is cholesterol treatment guidelines, a roadmap for an effective cardiovascular prevention in clinical practice. Now, these are the few points then in the next 35-40 minutes we'll be going through together. Now, the first one is LDL and cardiovascular disease. It is a fact, not an hypothesis. We hear still quite often that LDL cholesterol is weakly related, is something made up by pharmaceutical company actually to earn money. Well, in 2017, these colleagues from the European Society of Cardiology and the European Atherosclerosis Society said, okay, the LDL hypothesis has become an axioma. Axioma is something that is self-evident and therefore no longer needs to be demonstrated because they gather so much information about cholesterol in animal models, in cell culture, in human models, both genetic, in epidemiologic data, interventional study, you name it. And there is no point to actually doubt that cholesterol is causally related with cardiovascular disease. It's not only cholesterol, but as you all know, it's LDL cholesterol that is usually the primary target for both screening, diagnosis, and measurement and management of cardiovascular disease. So today we'll be focusing on LDL as the main priority to prevent cardiovascular events. The other key point before moving on is a very clear piece of information comes out from the trial we have. I can include bempedoic acid, the most recent trial. It fits right on this line. Here you see different ways of changing lipids and decreasing cholesterol: ezetimibe, fibrates, resins, niacin, not very used diet, a surgical intervention, the trial with the meta-analysis with statins. And what you see here on the x-axis is reduction, absolute reduction in milligram per deciliter or millimole per liter, and reduction in cardiovascular events. You see all these symbols fold around the line, suggesting that no matter how you reduce the LDL, the cardiovascular benefits are easily predicted by the amount of LDL you reduce. And it looks like there is no actually thresholds to limit these benefits. So no matter how you reduce LDL, you get a benefit. Now, the other point, looking at the guidelines, as Carlos mentioned for hypertension, the similar concept is true for cholesterol. There is no such a thing like a level above which you are at risk for cardiovascular disease, below which you are safe. But the levels are tailored according to the cardiovascular risk. You've seen this slide time and again, but I'd like to point out a couple of things that you might have overlooked. Because everybody looks at the numbers and say, oh, look, 70 milligrams, 55 milligrams, these are challenging, actually, numbers. Before getting to the numbers, let me show you one or point out a couple of points. First of all, very high. We associate very high with established cardiovascular disease. Not true. The large majority of the patients in the very high cardiovascular risk category are patients with severe chronic kidney disease, patients with diabetes, for example, and retinopathy, or 3 or more risk factors. So patients without cardiovascular disease, but chronic kidney disease or diabetes and target organ damage have a very high cardiovascular risk with a very challenging goal. The high cardiovascular risk includes, once again, moderate, not severe, moderate chronic kidney disease, GFR 30 to 59, diabetes without target organ damage, but with a long duration of the disease. Now, why am I showing these two groups? You say, well, because the goals are quite challenging. No, wait a second. There is a second point we overlook. Both these groups, the first approach, require to cut the cholesterol at least by 50%. So not only reach the goal, but the first approach needs to decrease the cholesterol by 50%. If somebody starts at 75, 80 milligrams already low LDL cholesterol, it's not enough to reach 55. You have to cut by a half the LDL cholesterol. So this is very crucial. Now, these are guidelines and recommendations coming from the Middle East region, 2021. Again, groups, high cardiovascular risk, diabetes and microvascular and organ damage, or chronic kidney disease, stage 3 and 4, no other risk factors. Very high, again, diabetes and target organ damage, retinopathy, nephropathy, chronic kidney disease, stage 3, 4, plus one or more risk factors. And then extreme risk, there is another category. That includes, of course, those with previous cardiovascular events, but also diabetes plus microvascular and organ damage, once again, chronic kidney disease 3 and 4, with established atherosclerotic cardiovascular disease. So even guidelines from actually the Middle East recognize that a number of patients, particularly patients with diabetes and chronic kidney disease, have a high, very high of extreme risk. They also suggest actually specific numbers. For high risk is 70 or less. For very high risk is reduce at least 50%, and you reach or aim to reach 70. And for the extreme risk is once again to reduce by 50%. The guidelines are very similar to the European guidelines by the EAS and ESC, and reach, if possible, 55 or less, or 1.4. So international guidelines, even in the Middle East region, agrees that there are patients at high and very high risk, even without having had cardiovascular events before. These are the results of the DISE study. It's a dyslipidemia intervention international study in the Middle East, and it highlights some interesting points. In that study, dyslipidemia was highly prevalent, 86% of all patients, and almost 62% at high risk did not reach the LDL goal. At that time was 70 for very high risk. Now, these are again referring to an older set of guidelines. Most patients, and we're talking about 83% of patients in that area, are at very high risk of cardiovascular complication. Diabetes is heavily represented in this group. Obesity, metabolic syndrome, very prevalent, more prevalent in women, 59 versus 51 respectively for the obesity, and 82 versus 72 respectively, women versus men, as far as metabolic syndrome is concerned. And of course, the lipid profile associated with diabetes, metabolic syndrome, low HDL and elevated triglyceride is observed in roughly 50% of the patients in that area. And the prevalence of diabetes mellitus was about 66, 68% in men and women specifically.
I'm sorry for the interruption, doctor.
Yep.
But we have a little bit of technical issue. Can you give us just 1 minute to fix it?
Of course.
Because
Yeah.
the audience
Don't worry.
can see the screen, okay?
Don't worry. You let me know when we can start again.
Okay, sure. Okay, Dr. Zambon, you can start.
Thank you. Thank you very
Okay.
much. Where should I start? Were you able to listen to these slides? I mean, the presentation?
Yeah, we were listening, but we couldn't see the slides,
Ah,
unfortunately.
okay.
Yeah,
This
but
one. So
we were
this is from
we were hearing.
DISIS, actually. Basically, it tells you that the prevalence of dyslipidemia is very elevated in the Middle East region. Also, an 83% patients at a very high risk of cardiovascular disease are quite prevalent. Among them, diabetes is well represented. Obesity and metabolic syndrome, more frequent in women, but frequent in men as well. 59 women, 51% for obesity, and 82 and 72 men and women with the metabolic syndrome. And of course, I was suggesting that the low HDL, high triglyceride phenotype, lipid phenotype, which is peculiar of insulin resistance, obesity, and metabolic syndrome, is quite prevalent, about 50% of all patients. Now, what to reach those specific goals, or the 50% decrease we have to aim at when we have high and very high cardiovascular risk, what should we do? This is the algorithm of the 2019 ESC/EAS guidelines that basically suggests, okay, check your risk level. You look at the baseline LDL, you define whether a treatment is needed or not. And if the treatment is needed, you use a high potency statin at a high recommended dose to reach the goal. This is step number one. Then you check again the lipids after 6 to 8 weeks. If the goal is not achieved, you add an oral agent called ezetimibe, often available in a single pill with a statin combination. And once again, wherever it's allowed, if the goal is not achieved after another couple of months, 2-3 months, check the lipids again, you add PCSK9 inhibitors or bempedoic acid if it's available. Now, we tend to forget that of the statins we have available, if we deal with patients at high and very high risk, which means 95, I would say, % of patients with diabetes, and we need to achieve a 50% LDL cholesterol decrease, there are only two statins that are able to do it: rosuvastatin up to 20 and 80 milligram of atorvastatin. Any other choice, it's not appropriate actually to reach the specific goal of 50% reduction. The reason why I'm suggesting that is that I'll show you what happens in reality in Italy, and you'll be surprised. So 2 statins, only 2 doses of rosuvastatin and 1 dose of atorvastatin. Now, the LDL reduction is predictable. Of course, we have variability among patients, but it's overall predictable. And this table, once again, from the recent guidelines, suggests that with the high-intensity statin, we may expect a 50% reduction, which is what we want to achieve. High-intensity statin monotherapy. Different statins have different actually properties. Rosuvastatin and atorvastatin, of course, you have a long half-life. In fact, it's 14 hours for atorvastatin, for rosuvastatin, 19 hours. That allows us to give these statins any time of the day, and they keep their actually effectiveness in the morning or in the evening. The older statin, particularly simvastatin, as you can see, the half-life is much shorter, were given in the night because the time where cholesterol synthesis is greater in the body is very early in the morning, talking about from 2 in the morning until 4, 6 in the morning. No need for rosuvastatin and atorvastatin. Bioavailability, it's quite high. There is a strong protein binding, actually, and there is a very limited interaction with the cytochromes in the liver. Renal excretion is about 10%. Making actually rosuvastatin, pravastatin, actually those that are more kidney secreted. Hydrophilic as compared, for example, to atorvastatin, which is lipophilic. So some peculiar features of rosuvastatin. Now, when you look at among high-intensity statins, the effectiveness, and you compare with the very commonly used statin, simvastatin, at different dosages, these are patients with atherogenic dyslipidemia, a huge number. It's 21,000. And you look at patients that started at the baseline, these are very high and very high risk. You look at patients that started at 130, 160 milligram, and you see the millimoles here as a baseline. The percentage of patients that achieved an LDL cholesterol below 70 with rosuvastatin 10, 20, already 60%, and 40, atorvastatin at different doses in blue, and simvastatin in yellow. As you saw, I mean, clearly, the rosuvastatin 20 was able to reach the goal in about 60% of the patients. So that, of course, tells you the potency of the statin. Now, they also looked in this Voyager trial at patients that started with the baseline LDL cholesterol lower than the group on the top. So the baseline was 130. And again, the goal at that time for very high risk was 70 milligram or less. And as you can see here, the percentage of people achieving that 70 milligram or less was about 80% with the Atorva 20, and that almost, but not yet achieved with atorvastatin 80. So rosuvastatin 20, 80% of the patients starting level of LDL less than 130 achieved an LDL cholesterol less than 70. As you can see, Simva 20 and 40 was way less effective. When you look at the effect on coronary plaque, you all know that there are some technique called intravascular ultrasound. There is a new technique called optimal coherent tomography, but the ultravascular ultrasound studies allows us to measure the volume and the area of the plaque. So, of course, it was quite interesting to see whether the reduction in the event, which is highly significant by reducing cholesterol with high-intensity statin, was indeed the results of changing in the phenotype of the plaque. And as you can see here, let's follow the green line. The dots sitting at the bottom of the solid black line means that the percent atheroma volume decreased. That's a negative number. And as you can see here, the only trial that showed a decrease in plaque volume were those using rosuvastatin 40 or atorva 80. Particularly, they found out that to have a plaque regression, you need to indeed to reach levels of LDL cholesterol that are less than 80, less than 70. So that's the interesting point. Two of these trials, Asteroid and Saturn, had the rosuvastatin 40. And let me give you a picture that is taken, in fact, from Asteroid, where they were taking 40 milligrams of rosuvastatin 24 months. This is the baseline on the left-hand side of this slide, the baseline picture. The catheter is here in the middle. Here is the lumen. Then you have, of course, the arterial walls, and then the elastic, external elastic membrane. At the baseline, as you can see, the red is the lumen. The atheroma volume of these patients was 10.63 square millimeters. After 24 months of rosuvastatin 40, the atheroma volume shrank to almost 7 square millimeters. Of course, because of the elastic properties, actually, the volume didn't change very much. The lumen area didn't change very much. On the other hand, the atheroma area significantly decreased. And this is associated with, of course, clinical benefits. Now, having said that, we also have available, and it's suggested in extremely high-risk people and people post-acute coronary syndrome, high-intensity statin in the same pill of ezetimibe. It's becoming quite popular, and it's becoming in Europe by cardiologists the preferred approach to discharge patients with. So here it's a second step indeed. So it's used actually only in patients that theoretically, if you follow the guidelines, that already has or have on board a high-intensity statin, but they do not reach the goal requested. So now the step 1 and step 2 in certain conditions are melted together, and they represent the new step 1 for certain patients at the very high risk. Now, one thing I like to show you is that by adding ezetimibe to any statin at any dose, you get a further LDL cholesterol decrease, which is far greater than doubling the dose of the statin. Here you have, this is a meta-analysis that works, a review, a meta-analysis that summarized the work of 35 randomized controlled trials, so a huge number of patients. You see simvastatin in the middle, atorvastatin, and rosuvastatin on the right-hand side. The gray bar suggests what happens if you double the dose of the starting statins. For example, if you look at the rosuvastatin, you start with rosuvastatin 5, doubling the dose of a statin, you have about 80% extra decrease in cholesterol. And here you see what happens when you double the dose of atorva and simvastatin, the gray bar. Now, when you add ezetimibe, and this is the interesting point, for example, with rosuvastatin to the starting dose, let's say 5 rosuva or 10 rosuva, atorva, same thing, 5, 20, 10 or 20 or 40 atorva. What you get here by adding ezetimibe, it's a decrease in cholesterol that is equivalent to having 4 times higher the dose of the statin. So rosuva 10 plus ezetimibe is equivalent to rosuva 40 in terms of cholesterol lowering. So adding ezetimibe, no matter what statin are you using, no matter which dose are you using, is equivalent of having quadruple dose of the statin you're talking about. Now, this is, of course, taking into account by the guidelines and the table that look at the intensity of lipid-lowering treatment and the average LDL cholesterol reduction suggests that high-intensity statin plus ezetimibe is able, the combination, to reduce LDL by 65%. Now, 65%, if you look at the line just below, it's PCSK9 inhibitor monotherapy. That's 60%. So just oral therapy, we have a 50% high-intensity statin, 65 high-intensity statin ezetimibe. We have a very strong and powerful tools to lower LDL cholesterol that's way less expensive than PCSK9 inhibitors that, of course, are highly effective and should be used as an add-on therapy. How effective is the combination? That's why the cardiologist actually right now suggests, for example, in certain patients, post-ACS particularly, to start with the combination high-intensity statin ezetimibe. These are French cardiologists, a paper that was published 3 years ago, and they look at patients that were admitted for acute coronary syndrome. Not on the statin, they said, okay, if somebody is admitted to the hospital for an acute coronary syndrome, LDL above 100, we'll start immediately with high-intensity statin and ezetimibe. Let's say the other patient is admitted on a statin therapy, but not adequate, so the LDL remains above 70. At that time, the LDL goals were still 70. Let's discharge them right away with statin ezetimibe. So they look at 270 randomly selected patients, of course, at very high risk. At the admission, the LDL cholesterol was 120 milligram per deciliter. 76 were compliant with the algorithm, so almost everybody had high-intensity statin, and about 70% in combination with ezetimibe. So the LDL target achieved after 2 months was 65% if the target was 55 or less, and 85% with the target 70 or less. So the majority of patients with the high-intensity statin and ezetimibe were able to reach pretty challenging goals after 2 months. So this is why, and this is a recent publication by a number of colleagues, the presidents of the European Atherosclerosis Society, president and past presidents of the European Society of Cardiology. They say, look, in patients at the very high risk, let's start with the combination statin ezetimibe, and eventually we add the third drug if the goal is not achieved. In those at extremely high cardiovascular risk, we may consider to have a PCSK9 on board at the discharge. So they said, let's move away in these patients from the paradigm of statin monotherapy, and all these patients at extremely high and very high should be treated with combination because it's simple. Wherever it's available, it's one pill. It's very inexpensive. It's highly effective on LDL, and it's very safe because even the dose of the statin, usually you can get up to 20 atorvastatin, 20 rosuva. Adding ezetimibe, you reach the same LDL cholesterol lowering of the top dose of statin monotherapy. Why is this relevant? This is a piece of information that is taken from the Swedish nationwide cohort study. It's a Swedish registry, very well taken, very large registry, almost 41,000 patients, 4 years on average of follow-up. They look at mortality and major cardiovascular events as they were predicted by an LDL between 6 to 8 weeks after the myocardial infarction, okay? So 6 or 8 weeks, which means immediately after discharge. And they look at 4 groups. Those who had the least actually decrease in LDL cholesterol after 6 to 10 weeks, less than 14 milligrams, as compared to other groups up to the one that got the greatest LDL cholesterol reduction 6 to 10 weeks after discharge, the event, greater than 72. And as you can see here, major adverse coronary events up to 9 years, in those who had the least LDL cholesterol reduction were almost twice as high, the prevalence, and those as compared to the purple line, those who had the greatest reduction. All-cause mortality was amazingly higher in those with the lowest LDL reduction after 6 to 10 weeks, as compared to the purple line, and myocardial infarction as well. So these colleagues suggested that the larger and early LDL reduction with an intensive lipid-lowering therapy is associated with the reduced hazard ratio of cardiovascular outcome and all-cause mortality. So earlier LDL lowering confers a significant benefit. Now, we need to use high-intensity statin in patients at high and very high cardiovascular risk. We may want to consider the combination in certain situations like post-acute coronary syndrome in patients that are typically seen by our colleagues, cardiologists. How do behave in real life? Well, that's a Da Vinci study. It's a survey published in 2020. They look at a number of European countries, and basically they look at implementation of the old set of guidelines, 2016, and the new set of guidelines, 2019. So what is the percentage of people, in this case, at the very high risk that achieved the target? 2016, the target was less than 70. And you can see here, roughly 40% were achieving targets. Now, of course, that number is even lower. 2019, now the goals are down to 55, and the numbers of patients, percentage of patients in different groups, established atherosclerotic cardiovascular disease, coronary disease, peripheral disease, and cerebral disease, reach at the best 20%. So why are we getting such a disappointing number? 39% looking at the old guidelines, 18% at the new guidelines. Well, the reason is, in these patients at the very high cardiovascular risk, in more than half of these patients, we're still using moderate intensity statin. Only in 20%, we are using high intensity statin that should be the therapy of discharge of these patients. Of course, ezetimibe in combination with the statins used only 9% of the patients. These numbers are currently getting slightly better because, of course, of the information that is coming out. And these are again very high-risk patients with established coronary artery disease. As you can see here, most of these patients are on moderate intensity statin monotherapy. Only 38% of these patients are on high-intensity statin. And if you look at the goal achievement, in fact, you look at the goal achievement with high-intensity statin monotherapy is better, way better, of course, than moderate intensity statin. It gets even better when you have a combination of high-intensity statin and ezetimibe. So the message is we have very effective and safe drug. We tend to underuse this drug. So what is the problem? Well, one of the problems is named here. It's called clinical inertia. So in Europe and in the United States, North America, what happens is that most of the patients after discharge or after the first visit by the diabetologist, cardiologist, lipidologist, they receive a lipid-lowering therapy, and unfortunately, that lipid-lowering therapy is not changed in the follow-up visit, even if the LDL goal, the therapeutic goals, are not achieved. That is called clinical inertia. So it regards all major risk factors that require, of course, chronic care. So hypertension is one, but particularly dyslipidemia is highly involved. It is very prevalent, and of course, it represents probably a risk factor by itself. So clinical inertia is something that happens. There is a recent paper published by the 5 top clinics in Europe's outpatients, interventional cardiologists, and when they see the patients after 1 month from discharge, 3 months, and 1 year from discharge, in all these 3 time points, more than 55, 60% of the patients do not reach the goal. Top cardiology centers in Europe. Now, inertia, it's very prevalent in the Middle East area, actually, as well. This is CFIUS, actually, so it's centralized pan-Middle East survey. Actually, you see the countries down here that were involved. And most of the physicians in that region are hesitant, as they are in Europe, as they are in North America, to use potent dose of highly effective statins. 77% of patients in CFIUS trial remained on the same dose of statins since it was first prescribed. So rarely the high-dose statin was used, and it was rarely changed during the follow-up. High-intensity statin use, which is statin dose potency 5 and 6, particularly in very high-risk people, you see the percentage of patients that are receiving it. Only 34% 8% of very high-risk population are on high-intensity statin, and approximately 26% of these patients actually, from, of course, data are available, are receiving other lipid-lowering treatments, even other than statins, actually. You can see it's true everywhere. It's not just data from Middle East. So clinical inertia is a problem. Adherence is the other problem. So here you see patients that are at high risk of cardiovascular disease initiating statin monotherapy. High-intensity statin, after about 20 months, half of the patients had either decreased or stopped the use of the statin, discontinued. Those on moderate low-intensity statin, that number, the 50%, was achieved even earlier, after 15 months. Now, stopping statins and stopping lipid-lowering therapy, and this is a study on about 1,000 patients with stable coronary artery disease, self-reported as non-adherent, increased by 4 times the risk of stroke and almost 4 times as well the risk of coronary heart disease. So it's not without consequences. They stop the drug, and they, of course, incur into high risk of getting recurrence of either cerebral ischemia or coronary heart disease. Just to give you an idea, in Europe, the tendency of coronary heart disease mortality is decreasing thanks to the decrease in the first year after the episodes. After a year, the mortality rate are plateaued, they are flat. The reason why? Well, of course, not properly treated and non-adherent patients. So, of course, if you don't take a drug, that drug, of course, cannot be effective. Now, why am I mentioning also adherence? Because I mentioned in the last part of the talk the possibility to combine ezetimibe on top of high-intensity statin. That's one extra pill in patients that already have, as we've heard from Carlos, antihypertensive combination, sometimes one or more pills. If they have diabetes, they have glucose-lowering approaches, they may have aspirin. So it's a group of patients that indeed take a very high number of pills. And one thing that is very clear is that as you increase the number of pills, adherence gets worse and worse. So that's why it's popular also to decrease the pill burden. So the best prevention to improve medication adherence is something we should do before actually we discharge the patients, patient counseling, information, but try to decrease the burden of the number of pills. And then, of course, after prescription, clearly the follow-up is very important. So decreasing pill burden, actually, it's something that can be done with combination, fixed dose combination, single pill, containing 2 and even 3 agents. What you have here in terms of adherence, the data coming from our colleagues that treat hypertension and diabetes are very clear. 2 compounds in single pill fixed dose combination are associated with a far better adherence that the 2 pills separate. And this is, once again, coming from Italy. It's a large database where they look at fixed dose combination statin ezetimibe as compared to 2 pills. Now, fixed dose combination was associated with an increased adherence by 87%, greater adherence than the 2 pills separated. Both males and females, greater adherence. Age, 3 groups, adherence was much better, and clinical status section. Rosuvastatin and ezetimibe was associated with a more than twice better adherence. The interesting point, so 87%. When the high adherence was associated with a significantly lower risk for composite outcome. Now, when you adjust for drug strategy, that difference goes away, which means it's really the single pill. It's nothing else. So after adjusting for drug adherence, that disappears. So it's really the adherence, and the adherence is better with a single pill combination. So let me, before presenting a clinical case, let me give you the take-home messages, very practical ones. The new goal suggests that we need to, particularly for patients at high and very high risk, but as you might very well recognize, chronic kidney disease, severe to moderate. Diabetes, any case, even diabetes without target organ damage, but with at least one risk factor, are associated with high or very high cardiovascular risk, even if these patients do not have previous cardiovascular events. In these patients, the goals are challenging: 70, high risk, 55 or less, very high risk. But let's not forget that this group of patients need to have at least a 50% reduction in LDL cholesterol. There are challenges from therapeutic standpoint. The LDL reduction greater than 50% is only seen in patients with rosuvastatin 20 and 40 and atorvastatin 80. So it's relatively simple as an approach. On rosuvastatin 20 or greater, 60% of the patients are at goal for less than 100. Those are moderate risk. Almost 50% are or achieve goal when the LDL is less than 70, 20% when LDL is less than 55. Now, the high-intensity statin, as we saw, in the real life is remarkably underutilized. In the real-life setting, both GPs and specialists, cardiologists, lipidologists, diabetologists, 20 to 35% at the best of patients that are at high and very high risk use high-intensity statin monotherapy. Now, high-intensity statin monotherapy represent a key pharmacological approach for coronary plaque stabilization and regression. We saw the data from asteroid. Plaques volume gets smaller when you get high-intensity statin. Now, the combination of high-intensity statin, an example, rosuvastatin, for example, or ezetimibe, provides a further boost in terms of LDL cholesterol reduction, 65%, and 80 to 65% of patients are at goal, 80% when the LDL is 70. As I showed you in the trial published by our French colleagues, post-ACS, 65% were at goal, when 55 was the limit, after 2 months, so very soon after discharge. So a rapid and effective reduction, particularly after acute coronary syndrome, is a key factor for long-term reduction in all-cause mortality and major cardiovascular events. Remember the Swedish register data. Plus, if you start with the proper approach, you kind of get rid of the clinical inertia because, of course, you start already with a pharmacological approach that is able, in the majority of the cases, to take your patients to the goal without changes. You remember in Europe, we had the treat to target approach. So you treat to achieve a goal, 55, 70. The ACC/AHA, although recently they changed and reverted back to the target, they suggested fire and forget. Simply use the maximum dose of high-intensity statin or the maximum dose of the statin that the patients can tolerate, and don't even bother measuring cholesterol. Of course, both approaches had some problems. So according to what I just said, I like to propose and suggest you a new paradigm that takes the best from both. The new paradigm is fire to target. Fire because you need to use the proper dose from the very beginning. No titration, because we know simply did not happen in the past, does not happen in the present. And then to target, because we need to maintain goals, and the goals are, again, numbers, 55, 70, but percentage, 50% less in high and very high-risk patients. Let me give you finally in the last 5 minutes, 10 minutes, a patient's case. This is a man, 55-year-old bus driver with hypertension, well controlled with the pharmacological approach, strong family history of type 2 diabetes and cardiovascular disease. Dyslipidemia since 2017. I was not treated. It was kind of overlooked for too long. Never smoked, referred to by his GP for dyslipidemia. When we saw him, he was gaining weight over the 3 years before the visit. In fact, current weight and height led to a BMI that was actually on the verge of mild obesity, almost 31 of BMI. The waist circumference suggested he was centrally obese. Blood pressure, nicely controlled. He had this recent ECG, no problem. Carotid ultrasound, just a max intima media thickness of 0.7, no plaques, normal echocardiography, no further remarks. ACE inhibitors, amlodipine, and aspirin were the therapy we looked at it. So no lipid-lowering agents. When we saw the blood test, clearly the guy had diabetes. No treatment, so he came to us with clearly a hemoglobin 1C and fasting glucose that were both compatible with the diagnosis of diabetes. When you look at the LDL, it was about 137. These are all numbers in milligram per deciliter. 39 was the HDL cholesterol, and triglyceride 178. So the guy was obese, intra-abdominal obese, with type 2 diabetes, hypertension, so diabetes and one risk factors. As far as we knew, no carotid plaque, no abnormality in the ECG or echocardiograms. We didn't look at, and of course, look at the blood urine, the albumin to creatinine ratio was not compatible with microalbuminuria, so negative. And we didn't have the eye fundoscopy, actually, in fact, was suggested, but a family history of cardiovascular disease. So diabetes and one risk factors for cardiovascular disease, but without target organ damage, falls into the category of high risk. So we need to cut 50% the cholesterol of this guy. The goal is 70 milligram per deciliter. If you look at the non-HDL cholesterol, which is a parameter that is rapidly gaining #1 priority in patients with diabetes, because it includes lipoproteins that are also triglyceride rich, is 100. When you want to look the non-HDL cholesterol goal, you add 30 milligrams to the LDL goal. So LDL cholesterol goal is 70, non-HDL is 70 plus 30, 100. So this is the table of the cardiovascular risk categories. As you see here, by the way, patients with diabetes, as I mentioned, fall into all these 3 different categories, but particularly our patients falls into the high risk, has diabetes, probably long duration, no target organ damage, but 1 additional risk factor, hypertension. Now, high-risk patients, the LDL goal, as I mentioned, is less than 70 milligram or 1.8 millimole. And the approach, and this is a class 1A, the evidence, the approach is high-intensity statin therapy, okay, with the class 1A. So it's a very, very simple case. What's wrong? He got discharged or got out of the lipid clinic visit with simvastatin 20. I mean, come on, it's simvastatin 20. I mean, was nice. ACE inhibitor, hydrochlorothiazide, aspirin was the pre-existing therapy. Metformin and sitagliptin was added. The fundoscopy was suggested, actually, and he was discharged with simvastatin 20. So there is no way that is a proper approach. You may say, well, this is not a very good lipid clinic, but let me show you why this is the most common statin used in Italy. This is 2022 data, recent data. 3,000 patients with diabetes. They look at the LDL cholesterol distribution, the top series of panels you're going to see, and the lipid-lowering treatment, the bottom panel you're going to see. As I mentioned, out of all these 3,000 patients, the large majority are at the very high risk, the others at the high risk. Very high risk. Look at the target. How many people reach the target? 9%. High risk, like our patients, 10%. But what is embarrassing to show, and these are diabetes center specialists that should take care of diabetes from a glucose standpoint, blood pressure standpoint, lipid standpoint, of course, to prevent micro and macrovascular complications. This is the embarrassing data. What is embarrassing is that more than half of these patients in both groups had an LDL cholesterol greater than 100 milligram per deciliter. So far away from the goal, it's almost twice. Now, guess what was the reason? These are data 2022, not of the last century, not of 20 years ago, but compatible with the simvastatin discharge that we saw the previous slide. So the problem is statin monotherapy is still, of course, and you say, well, that's not a problem, the therapy in these large number of these patients. But 71% of the statin monotherapy is represented by simvastatin. And at which dose? 20 milligram per deciliter. So exactly the statin that we saw the other patient discharged. So this is how far we are from reaching a decent LDL cholesterol control in our patients. And of course, when we saw the patient 3 months later on simvastatin 20, the LDL by weight, of course, glucose improved significantly. LDL went down from 137 to 98. No changes in the other parameters, no changes, well-tolerated therapy. Fundoscopy, by the way, showed no sign of diabetic retinopathy, but again, this is far from 70. And of course, because if you look at the slide I showed you before, of course, the 50% is achievable only with the Rosuva 20 or Atorva 80 in monotherapy. Well, simvastatin 20 milligrams is able to reduce the cholesterol anyway between 30 and 35%, which is what happened. And that's why in the previous slide I showed you the large majority of patients with diabetes in Italy remain with such a high LDL cholesterol and very few reach the goal. It's similar in many other countries in Europe. So on the second visit, basically, we took care of what we did wrong on the first one. So instead of simvastatin 20, we put the patients on rosuvastatin therapy, 20 milligrams, confirming the remaining therapy. Again, we took note that there were no signs of diabetic retinopathy. And what we saw after 6 months from the first visit is that the LDL cholesterol rosuva 20 went down to 68. No changes in blood glucose. 68 means versus the first visit is a decrease by 69 milligram per deciliter from 137 to 68, about 2 millimoles. In terms of percentages, 50%, which is, again, what you expect on average in these patients. And remember, you should keep in mind that in patients with diabetes, such as our clinical case, NA, every millimole of decrease in cholesterol, and this guy had almost 2 millimole decrease in cholesterol, so about 60, 70 milligram per deciliter, you get a 27% in non-fatal MI, 25% in coronary vascularization, 24% in major coronary event, 20% decrease in coronary death, 16% in stroke, and 10% in all-cause mortality. So my message is, we have the approaches, let's use them. Because if we don't use a significant and effective approach from the very beginning, we're going to miss the point. We're going to miss the goal. Last but not least, let me just tell you an interesting point that came out about 2 weeks ago at the meeting in Portugal, the country of Carlos Aguilar. There was a German pharmacologist that showed a very interesting study results that was done all over Europe. You know, they were looking at how patients trust their doctors. And one of the imaging that was extremely teaching a lot for me is that there was a clear line suggesting that the more the doctor changes the therapy, the lowest is the trust of the patients in that doctor. Practically, the patients believe that the doctor doesn't know what is going or she's going to do. So please, let's do proper therapy from the very beginning at the initial visit. Thank you very much for your attention. And once again, I'll be available for any of comments or questions you might have.
Thank you, Professor. Grazie di tutto.
Prego.
Thank you so much. Is there any question? Tempo delle questioni. It's right. Yep. Any question for Professor Zambon?
Thank you, Professor. I will ask you something little away from your lecture, but it's
no problem. Thank you.
With a little bit. This is about residual risk. In the recent years, there is a big talk and researches on the residual risk after we targeting the LDL cholesterol and reaching the target in many patients. Still, there is a residual risk of cardiovascular disease. And there are two main topics about triglyceride-rich lipoproteins and specifically very low density lipoprotein and drugs that target its development, or more important is small dense LDL cholesterol particles rather than concentration. So my question is, do you think we need in a near future to have these new drugs that are still in phase 2, maybe even phase 1 trials to target development of very low density lipoprotein, or in future not to develop small dense LDL cholesterol, or we need to just concentrate in statins and a reduction in LDL cholesterol as you see in your lecture? Thank you.
Thank you. It's a fantastic question, because I think it's really a key point of current cardiovascular disease prevention. I showed you in the DISIS data the high number of diabetic patients in your region, the fact that they have a problem in terms of LDL, they have a problem in terms of triglyceride. Now, clearly, the evidence of the past 7-10 years highlighted that the LDL are not the only atherogenic lipoprotein. We have triglyceride-rich lipoproteins that are equally atherogenic. Now, the problem is, as I showed you in the slides, that we are still far away from controlling the LDL properly. That's the other point. And the LDL remains the target number one. So we are far from controlling LDL cholesterol in patients with diabetes properly. So that's a high priority. But I agree with you, we need to look at triglyceride eventually. Because even in trials using PCSK9 inhibitors where LDL cholesterol were down to 30 milligrams or lower, patients with diabetes remain at significant cardiovascular residual risk. So residual risk is an issue, and triglyceride-rich lipoprotein represent one of the key topics to reduce residual risk. LDL lowering agents, ezetimibe, statins, even PCSK9 inhibitors are not effective in reducing triglyceride-rich lipoproteins. So as you mentioned, in the future, once, of course, we achieve a nice control of LDL in patients with diabetes, we're still not doing that, we should focus our attention on triglyceride-rich lipoproteins. Just to give an idea how little attention we paid to these lipoproteins the past 30 years, I graduated from med school in 1988 with the thesis on dyslipidemia and diabetes. And the guy that was chairing the session asked me, what kind of drugs do you have to decrease triglycerides in patients with diabetes? And the answer were omega-3 fatty acids and fibrates. Now, 2024, if you ask me the same question, I will give you the same answer, omega-3 and fibrates. So in the past 35 years, we did not progress one bit in terms of decreasing triglyceride in our patients because simply we didn't think they were relevant. And unfortunately, they are very relevant. I'm looking very much forward to new approaches to lower triglyceride. The current approaches are with the omega-3, of course, you know, particularly icosapentaethyle seems to be effective even in those with normal triglycerides. So the effect of omega-3 icosapentaethyle highly purified is probably on top of triglyceride, inflammation, platelet aggregation. Fibrates with PIMA fibrate, we got some disappointing results. We have some interesting results with the old fibrate, phenofibrate, but definitely we are in deep need of trials that show that reducing triglyceride-rich lipoprotein, once the LDL are well controlled, provides reduction in residual cardiovascular risk. So yes, your point is very well taken. And once again, I think the key word is combination therapy. Combination therapy will be the future.
Another question here, Professor.
Yep.
Thank you very much for this highly relevant presentation. Since we are students, we have some problems with the lipid, either about physiology or pathology. My questions, before we have here that any statin is effective, just start statin. Any statin is effective. Now it's approved that it's not effective. So we shouldn't use this term anymore.
Yeah. Can I? Okay, I'll answer the first question, then you ask the second. Any statin is effective proportionally to the reduction of cholesterol. It is effective. Simvastatin is effective. 20 milligrams, you reduce the cholesterol by 30%. Simply, it's not enough according to the cardiovascular risk of our patients, particularly those with diabetes, for example. Those with diabetes needs more. And again, I told you the embarrassing data in Italy. It's simvastatin 20 is still the most commonly used statin in patients with diabetes. It doesn't take you anywhere. So statins overall are all effective. The effect is proportional to the LDL cholesterol reduction. In patients with diabetes, even without cardiovascular disease, but retinopathy, let's say, or nephropathy, you need a greater LDL cholesterol reduction than that can be provided with simvastatin, pravastatin, fluvastatin, whatever. So you have two statins and two dosages if you want to properly treat them. In the future, you may want to combine 10 milligrams of rosuvastatin and 10 milligrams of ezetimibe, for example. That's a good approach. We have it available in Italy. It works as much as 40 milligrams, but we need to properly treat the patients. And an easy thing to remember is that in these patients, we had to decrease by 50% the LDL cholesterol reduction, no matter where it starts. That's the first goal.
The other question, it has been mentioned in the guidelines for treatment of diabetes. Any patient after the age of 40 we have to start statin, whatever the lipid profile. So is it for life?
Well,
For life?
once you decide, yes, that's a good question. Once you decide to start a statin, it's for life. The reason why they said a diabetic above 40 is that most of these patients already have at least another risk factors. They are diabetic and obese, diabetic and hypertension. And thereby you may want, and then again, if they have early stage diabetes, they fall into the moderate category. So the goal is 100. In that case, you may consider a lower dose of rosuvastatin and potentially other statins, but that's very few patients with a very short duration of disease. So yes, the answer is once you start statin therapy, that's for life in these patients. Yeah.
The other question we have in the patient pre-diabetes patients who are diagnosed as pre-diabetes, and we know that they are subjected to more cardiovascular disease risk. So we are hesitating in starting statin because according to the Jupiter study, we may push them to diabetes. So which safest statin to be used so not to push them to blown
very good question. So number one, keep in mind that even Jupiter and the other trials showed that the benefits you receive by lowering LDL cholesterol far outweigh the small risk of increasing diabetes. Just to give you an idea, you need to treat about 250 patients with pre-diabetes to get one extra case of diabetes. And in the meantime, you save about 4 to 5 severe cases of coronary artery disease in the same number of patients for 5 years. It's not one thing that became clear. It's not the increased risk of new onset diabetes, which is small, but it's there. It's not associated with a certain statin. It's not somebody can say, well, it's hydrophilic, it's lipophilic, it's hypotensive. No. It's associated with the potency of the statin. Atorva 80 is associated with the greater risk of new onset diabetes than Atorva 10. Simva 40 is associated with the greater risk than Simva 10. Same thing, Rosuva 40 than Rosuva 10 or 5. So it's the amount of the potency of the statins, the HMG-CoA reductase inhibition, that affects the new onset diabetes. It's not peculiar of any statin. It's all the statins and depends on the potency of the statin. Now that you ask the question, I must say that ezetimibe is not associated with the new onset diabetes. PCSK9 inhibitors are not associated with new onset diabetes. Bempedoic acid is not associated with diabetes. So the small increase in new onset diabetes, and again, far outweighed by the benefits, so don't worry about it, the benefits are far greater, seems to be associated only with the class of drug called statins.
Thank you. Last question.
Hello, Prof. Alberto. Thank you for this nice presentation. It was very useful and comprehensive. As a diabetologist, we commonly face hyperlipidemia, particularly post LDL, and we start statins. We proceed from maybe Simva to rosuvastatin. Then, as commonly used by our regional cardiologist, is ezetimibe will be added, but we end up with hypertriglyceridemia. Triglycerides commonly raised in diabetes anyway because of hyperglycemia itself, so it's a common encounter anyway. We usually remain patient for a while regarding triglyceridemia till blood glucose is controlled, and we then reevaluate the need. But sometimes in cases of familiar hypertriglyceridemia or substantial rise in triglyceride, and the risk between two brackets for cardiovascular, we need to treat. So we add fibrate. My question is,
that is correct.
How safe is to combine these three agents? And how to monitor?
Yeah, it is a great question. It is safe. Of course, for example, one of the most common combination I use, as you said, some diabetologists start or add the ezetimibe first to further lower LDL cholesterol. Remember that ezetimibe prevents or an impact on postprandial lipemia. I mean, statins don't do that because of the mechanism of action, absorption, interfering with the absorption of lipids from the intestine. In the patients with diabetes seems to have a particular benefit, the addition of ezetimibe. Now, triple therapy, as you said, when triglyceride remains high, fibrates, and particularly for safety reason, only fenofibrate can be used. And it's not a very strong fibrate, but it's the only fibrate where we have evidence. It's indeed something that you need to associate. I have personally a significant number of patients with Rosuva 5, Rosuva 10, some of them with ezetimibe and fenofibrate. I must say the increase in transaminases or CK is not greater than single monotherapy. So it's relatively safe. And just to give you an idea, the Italian healthcare agency reimburse completely fenofibrate once you have patients with diabetes remaining with triglyceride above 200. So that is officially reimbursed by the Italian government, just to give you an idea of how safe is perceived by the regulatory agencies as well. So one of the things that I must mention in the end, since you were, I think, asking about creatinine levels with ACE inhibitors, I mean, these patients can have metformin as well, which is, creatinine levels is sensitive and GFR. You may expect with fenofibrate as any of the fibrates except PIMA, but PIMA, we will never have pimafibrate, as a tool. You may expect a slight increase in creatinine. Once again, the trial with creatinine, both Field and Accord, showed that even after 5 years, you stop fenofibrate, creatinine goes back to baseline levels, suggesting, of course, that it's a competing mechanism. It's not associated with renal damage. And if anything, both in Field and Accord, those on fenofibrate after 5 years had a better GFR at the end than those on statins or placebo. So at the end, fenofibrate is renal protective. Of course, you should avoid use of fenofibrate with a GFR less than 30 and be careful less than 50/40.
Thank you.
Alberto, this is Stefan from Germany.
Yes.
Very nice lecture. Buongiorno.
Thanks. Buongiorno.
I just wanted to add one thing because I just had to look it up. 2012, we had a paper in atherosclerosis where we showed that in people with type 2 diabetes and the small dense LDL fractions, the treatment with ezetimibe and simvastatin was the strongest to reduce small dense LDL.
Yeah.
And it seems to be that ezetimibe specifically, as you already mentioned, improves postprandial triglycerides.
That is exactly the mechanism. Yes, and again, it's not depending on any statin, but it's depending on the postprandial effect that ezetimibe has. So yes, absolutely yes.
Professor Zambon, we are really grateful for your participation and for
Thank
the
you.
lecture. And we're hoping that we'll meet again and again in scientific forums organized by Julfar. It's our honor to be with you today. And thank you so much. Waiting, inshallah, for upcoming events for your participation with us next, inshallah.
Thank you.
Thank you
I'll
so
be there
much.
in person.
Thank you,
Thank
Professor.
you, and enjoy the rest of the meeting. Good afternoon. Bye-bye.